Everyone for bearing with us as we get started here today. I apologize that we couldn't get everyone in the same location for an actual conference. I think most of you are probably aware by now of the new conference rules that are making it very difficult for us to hold conferences anywhere. We had to cancel the CST CWA conference and the Physician Champion conference, and there are a lot of other conferences now that many of you may have been planning to go to that are in question. So we're working, this is the first time we've tried this virtual training conference. I want to thank all of the training staff and the MAPS folks, and particularly Arlene and Eddie and Vicki and Elizabeth and Dr. Jones for working on getting this pulled together. So hopefully this will work for you all, but we'd love to hear feedback. I'm sure there will be some bumps in the road as there have been today, but work on getting through my slides. Some of these slides, if you were at the Northern Region Conference, and I'm not sure how many folks that are on will be some repeat, but I also have some updates, and I wanted to touch on a few things. Let me see, I'm just trying to figure out how can I move my slides down, or do you need to do that, Eddie?
You can do it, or I can do it for you, ma'am.
So it doesn't seem, oh wait, hang on, let me try it down here. Okay, I got it. So I want to just talk about a few things today and give you an update on kind of where we are with some of the topics that are there. MAPS, business intelligence, capability management, informatics workforce development, and the iEHR. And really these are the top things that I'm working on within the office of the CMIO during the next year, and wanted to make sure that people kind of know where the emphasis is, at least from our office's perspective. And here is the CMIO mission and medal, just for folks that haven't perhaps seen it before. Really just in a nutshell says what we're trying to do from our vantage point at OTSG MEDCOM, really to be that advocate for the clinical information systems for our providers, and provider in this case includes really all of our healthcare providers, not just physicians and nurse practitioners and PAs. It really is everybody out there in our healthcare system who uses our clinical information systems. And the medal that's listed there, those are the areas that we really kind of focus on. So establishing and maintaining trust among our healthcare provider community, I think, is really probably what it put in place the CMIO office back in 2008, and we continue to work on that. And I do realize that there is definitely a lack of trust from our folks on the front lines that the IT solutions we provide will really help them with their work. Unfortunately, often the things we're providing are making their job harder and not easier. And then the other things that I see that there's no audio. Is there, am I not being heard?
I can hear you loud and clear, ma'am.
Okay, I'll keep going. And so the other things that are listed there, I won't read them to you specifically, but all areas that you all are probably working in yourselves, but those are the main focus areas for us up at the CMIO office at OTSG and MEDCOM. So it's kind of interesting too watching these on DCO. So DCO gives you some interesting formatting on your PowerPoint slides, but I think you can get the gist of it. Here's our MAPS program, kind of in a nutshell. Many of you, I think, will be well aware of the MAPS program. And again, another key element here when this was started was to regain trust with our providers, increase satisfaction. Now we're moving more into that area of increasing clinic productivity and throughput and efficiency, and really transforming how training is conducted for all of our clinical information systems. We're focused right now on MAPS 2.0, and I'll talk about that a little bit. And MAPS is really a combination of tools and technology, not just IT, but it is about the processes too. Those of you that are the clinical workflow analysts know that very well. We do have 266 CSTs and workflow analysts that we brought in over the last several years to help at the MTF level, and that was really key because this could not be done just with technology. It really is about the people that are there to also assist getting us through this process, and we're really focused on effective knowledge sharing. So MAPS continues. I'm going to go into some more information on that. I do want to just remind people of what's in the MAPS toolkit, and you'll notice that on here it's not just the Dragon, As You Type, and OneNote, which a lot of times is, I think, what people feel MAPS is. Maybe not those of us in this field, but folks outside of the informatics community. And so keep in mind that the people are a part of this, the physician champions, and the fact that the operations order designates that they should have 4 hours a week dedicated to MAPS. That's really critical here. We've also added over time the Tri-Service Workflow AIM form and the AMEDD Clinical System Exchange, which are not necessarily a specific product per se, but it's a way to use our technology in a way that shares knowledge in the best way possible. So that's really the toolkit. And then just a comment here, because I know a lot of people have been working on implementation of what the operation order put out just a year ago. Now here, as it's the end of July 2012, and we got this out a year ago, and really MAPS 2.0 is our focus. Like I mentioned, focuses on really that team approach now, not just the pushing out the tools, but now it's about the entire healthcare team, how to standardize their workflow and provide a more comprehensive visit, as that last bullet there talks about, and is very linked to the patient-centered medical home initiative. And I know that the implementation timeline has been a point of discussion, particularly at the regional level. And we did have in the operations order that stages 1 and 2 would be implemented no later than the end of this fiscal year. Stages 1 and 2 really apply back to the patient-centered medical home initiative and those primary care areas, particularly the MEPRS codes that you see listed there, and then stage 2 going into some of those additional primary care areas like flight medicine, internal medicine, and pediatrics. CIRMC did come to us with a request to extend their deadline for getting phase 1 and 2 completed, and we are working now. We've done a lot of discussion with Colonel Wheeler and our MAPS team, and we have now decided to draft a FRAGO recommending an extension of the deadline for those stages 1 and 2, and that we'll be putting that together, and we'll need to get approval on that from General Horoho, as the operations order is really owned by the Surgeon General, not by the CIO. So be looking for that, and if there are any questions on that, we can talk about that at the end of the discussion here today. And I hope most of you that are involved with MAPS have seen this. This is an example of the SMS dashboard, and this was actually at the end of June, I think it was. So this is probably updated slightly in your particular regions. The SMS dashboard is the, or SMS, I'm sorry, is the strategic management system that we are now using at OTSG MEDCOM to track our balanced scorecard and our progress towards the various metrics that the Surgeon General has deemed important to manage and to monitor. There is a strategic session going on right now with the Surgeon General and many key staff from the MEDCOM, and so our balanced scorecard could change here in the future, but MAPS implementation is something we will still continue to track through SMS. And this is information that is entered locally by the regional folks to express how far along they are with their MAPS implementation. And as you can see, it gives you a quick look of how a region is doing. And we've just had this in place about 6 months. And so we're getting much better documentation of this. And I like the comment there from Mr. Thomas that says, wow, look at Europe. And so that's part of the plan here when you put a dashboard up, is to show everybody the information and compel really folks to achieve a greater percentage of success. So this is something that folks should be looking at, and keep in mind that this is subjective information that people are putting in from the regional level. There's not an actual place that we can go and pull electronic information or electronic data from to populate this. So is it perfect? No, but it is a reflection of what the region feels that they're at with regard to implementation of MAPS 2.0. And the MAPS metrics are listed here. These are actually available through the CMS portal, which is the Command Management System portal through MODS, and the metrics that are tracked are listed there: HEDIS, coding accuracy, etc. And several of those are also metrics that are being tracked for other programs, particularly PCMH and other things. And so it's really difficult to say that because a provider was using Dragon and OneNote that their HEDIS metrics went up. And we've struggled, quite honestly, with these metrics and trying to come up with metrics outside of just provider satisfaction that show the true impact of the tools that we have implemented and the processes that we've put in place. So Dr. Jones is still continuing to work this and try to refine these metrics, but right now these are the ones that we are tracking and that folks are looking at. Okay, that's the MAPS piece, and then I want to touch base on the MEDCOM business intelligence journey. This is an area of particular interest for Colonel Wheeler as well, and something that we're putting a lot of effort toward. This is really just sort of the problem statement, and I'm not sure that any of you are unaware of what's listed here. Unfortunately, this is pretty has been a problem for a while and is pretty well known throughout the MEDCOM, but that we have a lot of different data sources, a lot of different solutions for looking at our data, a lot of different types of analysis going on, really not standardized measurement across our enterprise, perhaps standardized measurement in an MTF or maybe across a region, but really no further than that. We have a lot of labor-intensive data extraction going on everywhere, lots of different labor-intensive analyses activities going on, and really a general, that last bullet, lack of coordination, management, and control for business intelligence. And so it's very difficult to really give folks like General Horoho and our key leaders a good sight picture of where the MEDCOM is with a lot of their different initiatives and programs, and really showing how well we are or are not providing patient care. And so this has been a problem that we've been trying to tackle for the last while. Unfortunately, it looks like DCO really kind of muddles this slide, but it's just a pictorial view of really our problem statement. And it's not just that we have a lot of data, which is that first bullet on the top left, that volume data comes in one size, large. We do. We have a lot of data, and the picture in the middle really tries to represent all of our various systems. And you see some things there listed that you may be very familiar with, probably some that you've never heard of. But we have the AHLTA, CHCS, Accentris, kind of the corporate systems that everybody uses. We have ICDB, we have MODS, we have MEDCOM, we have BHDP, the Behavioral Health Data Platform, Amputee Database, etc. It just kind of goes on and on. So it's not just about the fact that we have a lot of data, but it's also on that bottom left the fact that there's a variation in our data too. We have a lot of different kinds of data. We have structured, semi-structured, unstructured. We have text, audio, video, all those different kinds of things. So it's not like you just have financial data that you're trying to put together. It's financial with clinical, with subjective, with objective, etc. So it's a lot of variation. And then the top right shows the piece that there's also velocity here. Our data is not something that is collected once a year generally. The data we're trying to analyze is being collected real time all the time, and we want to analyze it real time all the time in order to get the most value from it. So that's just a good, I think, picture view of what we're trying to fix here. And so what we've done is we've kind of broken this into 3 phases. I'm not going to touch on all these bullets here, but I wanted you all to have the information. But we worked on an assessment. Some of you were probably part of that and were interviewed for that back in 09 to 10. And we really looked at what is it that people want to do with the data that they are entering into all of our multiple systems. And after that, we looked at all those interviews, and we looked at all of the information we gathered, and we tried to focus in on some things, and patient-centered medical home was one of the areas that we identified and started to look at for how we could support patient-centered medical home. And we had a clinical steering committee. They looked at all of the identified priority requirements, we looked at the NCQA recognition requirements, and we looked at some ways that we could support patient-centered medical home. And so then the second phase really was the establishment of some governance and the BI Competency Center. And this has been a real challenge because everyone and their brother is doing some sort of business intelligence in MEDCOM. And we've really got to get to more of a consolidated site picture on this, and governance was a key piece. We did partner with a couple different industry agencies with contracts to get some information and have them help us with this. We started, and I'll show you a diagram in the next slide of kind of how this is being set up, but we have really 3 layers of governance, and we've been working on this with regard to the BI Competency Center, and I'll touch on that in the next couple slides. We also have been working very much with the Air Force and the Navy and our tri-service efforts for the clinical enterprise intelligence, which is really the health services data warehouse down there on that towards the bottom of the slide. That has been designated as the way that we're going to do clinical enterprise intelligence for the 3 services and with TMA. And so that agreement was made, and we are partnered with Air Force on trying to really make sure that Army equities are achieved in that, and that we can get at the data that we want. I mentioned our governance structure, and here's the picture that I was talking about. At the top, we have a BI Governance Council, and on the next slide I'll kind of tell you who is in these groups. But really that's your highest level of governance, and they are the ones giving direction and setting the strategy for business intelligence. And in the middle, you have the BI Steering Committee, and they really are kind of one layer down, doing a little bit more of the work, but giving recommendations to the Governance Council and trying to enact the vision and the strategy that the Governance Council sets. And then on the base of the pyramid, you have what we are calling the Data Competency Center, which is comprised of several different groups. A development team is listed there, and the governance team, the data governance team, is listed there, and we're working on exactly which pieces and parts comprise that group right now. This slide here shows you the actual people or the positions that are in those various areas of governance. And so really the Governance Council has become and I apologize, I just realized that this is actually changed, and I did not get the accurate one in here, so I need to correct that, and I will do so for the archives. The Governance Council is not anymore the people you see listed there. With the changes at OTSG and us bringing in a G staff, that Governance Council is really becoming a Council of Generals, and so that will be led by Mr. Coley still, which is there, but now the G146, who is General West, will be on that governance council. The G357, who is Colonel Promotable Cho, will be on the council, and the G89, who is yet to be hired. That's going to be an SES one-star equivalent position. That person will be on that council. And really then the steering committee becomes all of the directorate chiefs at the OTSG MEDCOM level, and with Public Health Command in addition. And then the Data Competency Center at the bottom really is still pretty much the folks that are listed there. And so it gives you a lot of the reps from the various areas that need to be doing the work at that Data Competency Center level, gives you the directorate leadership at the steering committee level, and then your general officer steering committee essentially at your governance council at the top of the pyramid. So I apologize that that's not the updated one, but that's where we're heading with the actual governance structure. And this is where we're at right now, really, is we're still trying to get all of this implemented and running smoothly, and Jim Frazier is my lead on this, and he's doing a great job. It's very difficult bringing all the cats and dogs together because this is not just a CIO effort. This really is a total MEDCOM effort, and we're trying to get others to accept some of the authority here and responsibility, and so that's something we're working on. Other things that are listed there is that we are working on standardizing analytical capabilities throughout the MEDCOM so that our analysts that are out at all of the facilities in the regions can have some kind of right and left limits and some standardized toolkits that they can use. We also are working very much on integrating BI with the knowledge management framework that's being implemented. And so business intelligence and knowledge management really go hand in hand, and we're trying to bring those together much more closely. So that's kind of where we are today with the implementation of the governance, and then we also are really driving the partnership with TMA and our sister services that I mentioned now that Air Force is the executive agent for clinical enterprise intelligence. And that means we need governance at the tri-service and TMA level as well, so we're working to get that put in place. And one of the things that I am making sure that I brief kind of at every venue I can is that we still need more resources for this. There are some things that we don't have inherent in the MEDCOM, particularly data architect expertise, master data management expertise, big data expertise, and we probably are going to need to get some of that from industry because we really just aren't going to be able to grow that quickly. And big data in this instance does not mean just a lot of data. Big data is a new move in the IT arena, and it gets at those three areas of volume, velocity, and variance and variety, that I showed on the second slide of this portion of the brief. And so these are some things that we need to work on in MEDCOM if we're going to keep working on this. This is our desired end state where we'd really like to get, and I'm not sure how long it's going to take us to get there, but I think it's very possible to get there. We just need to get everyone working together as a team and understand what our desired end state is as a group, and agree to work towards that. But those are the things that we're looking at that are listed there on the slide. So really, I mentioned that trained analyst workforce. Ultimately, we want a culture of BI linked to performance management. Gets back to kind of the dashboard concept, and where you start to surface information and then encourage people to change their behavior to improve their outcomes. And ultimately, that self-service, self-analytics for both providers and patients. So our patients are also wanting to see their information more and more, and I'm sure most of you are in that boat too, from being a patient, not your employee perspective, but your patient perspective. We all want to know, how are my labs? What do my lab tests mean? How, do I need a prescription to be changed? Do I need a change in my disease regimen that I maybe have been started on, and what kind of information can I get sitting at my computer at home or sitting on my smartphone while I'm waiting for my child to be done with their dance lesson? What kind of stuff can I access as a patient that I will be able to use to improve my health? And that's something that we want to ultimately get to, is not just only the providers but the patients too. And so next section I want to go into is just to touch on capability management. And some of you may have seen this in various venues. We're working very much on building in this capability manager function. And I'm just going to build this slide out here. And really what we seem to somewhat be missing is that bullet on the bottom where you've got someone who serves as the user advocate and counterpart to our program managers and coordinates with other capability managers, centers of excellence, and interacts with operational and institutional organizations on important issues to solicit their input. So essentially, as we are building all of the clinical information systems at the TMA and the DoD-VA level, how are we getting the voice of the user into those discussions? And that's where we feel that capability management can help us. The mission of the capability manager is listed here, and this is something that we are fleshing out right now. Dr. Colonel Young Do is back from deployment, and he has rejoined our office, and he has been put in the position of clinical capability manager, and he is working through how that's going to really be operationalized in our office, but it's all about making sure that the functional voice is heard at the table when we're defining the requirements, when we're building the systems, and when we're fielding the systems. And so you can see some of that listed here, and like I said, this is somewhat a work in progress. These are the areas where we're going to focus our functional capability managers on, and that's going to be clinical, business, and operational medicine. The clinical, as I said, is Colonel Young Do. The business is yet to be determined. We don't have a business capability manager yet, and operational medicine looks like it will be Colonel Dan Krall, who's currently our CTO. Colonel Paramore has just signed in today to be our new CTO, and he will be handing, taking those reins from Colonel Krall, and as Colonel Krall transitions, he will move into this operational medicine capability manager. And we will have a strong liaison from the CMIO shop to all of those folks, because every one of them has clinical components to it, and not all of those will have actual clinicians working with them. So they will reach out to the CMIO as a partner to work on those things. And we also are working on using this function to help drive our IT portfolio management. And so any of you who have moved from one or two locations to another will know that we unfortunately don't have the same standard systems out in our facilities for all of our functions. So we may have multiple endoscopy systems and multiple pharmacy systems and multiple documentation options for certain functions. And so we're trying to standardize that, and we are going to look to our capability managers to help us with that. And they'll help us during the investment review process and help us to determine which things we should be spending money on. And it's going to get harder and harder to spend money. I'm sure some of you are also feeling that in your locations. The money is not flowing as it used to, and so we really have to be careful and cautious on what we do expend our dollars on, and make sure that it's the right thing for the whole enterprise, not just one location. And so that's part of the role that these folks will play. And then Informatics Workforce Development I want to touch on, because I did not get to talk about this much in the NERMC conference for the folks that were there. And Arlene, can I just check how much time do I have? When do I need to be sure that I'm done by? Okay, so I may not get through all of the iEHR, but I want to make sure you all know what's going on with workforce development. Okay, so this is just a slide kind of depicting all of the various areas that we have been trying to start to focus on with our workforce development efforts. Right now I'm talking just informatics workforce development. However, General Horoho has asked Colonel Wheeler to really look at the entire IMIT workforce and what we need to do to ensure we have the right workforce either in place or being positioned and trained to be in place for the next several years. And right now we know that we don't have an adequate workforce. The areas that we've started to look at or that we want to look at comprehensively are all listed here. Acquisition, actually getting people on board, onboarding them, training them up, getting them, set in their role very quickly. Learning and development, how do you continue to develop folks and make sure that they're learning the most current information for their role. Performance management, you'll notice, is in gray. That's usually not something that we focus on, particularly when we're working on a contract right now. That has not been an area we've looked at, but we have looked at competency and what things people do need to be competent in certain roles, but we have not linked that necessarily to anybody in particular, how they're performing based on those competency measures. That's done through other mechanisms for us. Retention of staff is very important, and succession planning, very key, and we haven't really gotten to those yet, but those are areas we want to look at. And if you look at the next slide here, these are really the phases that we focused on. We're done with phase 1, we're almost done with phase 2, and we're going to be moving into phase 3. We have many different work groups. Most of you probably have either been part of them or heard about them or been part of some of the proof of concept that's mentioned there in phase 2. And so we are working through really identifying, if you look at the bottom and the key artifacts, we now know what our job families and our role profiles are. We have a competency model for all the informatics positions. We do have performance metrics, and so that will help our leaders as we go forward with evaluation and looking at the performance of folks. We do have a proof of concept plan and a gap analysis, and we're working on the workforce development strategy. And then going into the future, into the next year, we will have kind of the final report, marketing collateral, and really looking at, in this last phase, some of the pieces around succession planning and retention is what we're trying to focus on. And so these are some of the things that we've learned so far. There's definitely a need for this clinical informatics capability. I'm not sure any of you need to be told that, but it's very clear. There does seem to be growing alignment around the informatics strategy and vision and the way that we're actually implementing it in the field. Lots of effort around workforce development, but not all of it's been integrated and clear to the end users, so we're trying to bring some of that clarity to the fight. Leadership development is really critical. We've heard back during our interviews and the surveys that we've done that a lot of folks feel that they're really pretty competent in their technical aspects of their job, be that a clinical system trainer, a workflow analyst, or a CMIO, but they feel like the areas they need some help with more are the leadership development areas, management of people, guidance, mentoring and building teams, and those kinds of things. So that's something that we're going to work on. And then there's just a hunger for clarity around roles and responsibilities and how MEDCOM will support learning and development. So those are some of the other pieces that we've worked on. I'm going to go through this just very quickly. I'm going to hit on a couple slides because I want to leave a couple minutes for questions, but I do want to just touch on the iEHR. This is really just background. I think most of you know that the DoD and VA are now working on upgrading both of their electronic health records. We're doing this together. The SecDef and SecVA have made some agreements. Some of these agreements sound good on paper. Now trying to implement them has been a bit challenging, but this is kind of where we're heading, is to a joint solution. This is the governance model here. The only thing I kind of want you to focus on here is that over there in that yellow area is really where the functional voice gets to be heard. And this is through the ICIB, which is the Interagency Clinical Informatics Board. I sit on that board with Ann Wolford-Connors from our office, and that's a joint board with VA and DoD representation on it, and we're the ones that are trying to feed over to that interagency program office the things that we want to have built into our electronic health record. And you'll notice that Top level is the Secretary of Defense, Secretary of VA, and then their deputies. This is a very high visibility project, very political, and it does have the attention of the folks at that level, and they are really influencing it. The IPO, which is the Interagency Program Office, they have had they've been in place for a long time, but they were rechartered last October to really serve as the single point of accountability for all of the iEHR work and VELR, particularly VELR Health. And their responsibilities are listed there. Bottom line is just that is another program office that has now been stood up, and we are trying to work with them to get our EHR built and deployed. These are the functional capabilities and planning increments as defined by the IPO. This is a frequently adjusted product. We talk about, from a clinical perspective, the capabilities. The IPO now is talking about increments. We're still trying to kind of get a handle on what the difference is and how all of this will actually be rolled out. But I would not get too hung up on any of those dates there, thinking that they are hard and fast, but the general gist here is that we are hoping to have this all rolled out by 2017. And if you think about that, that means that we still have a good 5 years to be with what we have today, and I'll touch on that. This is a slide for you all to look at later. I don't want to focus on it right now, but this is the acquisition framework we're trying to use that the IPO has put out. The key thing here really is that we want involvement from you all and your customers in this process. We are trying to figure out how to best facilitate that. And so we're talking about some things like facilitating a process where we would have 2 or 3 different sites across the country that represent the different sizes of facilities, say an academic medical center, a community hospital, and a clinic, picking locations that have at least 2 services and the VA present. Maybe not present physically in the same exact building, but present in the same location generally and doing work together. And then what we're doing is talking about taking out the work out to those areas. So bringing the development teams out to those areas, working with say the internal medicine team, working with that internal medicine clinic, the physicians, the nurses, the techs, the LPNs, the lab folks that support them, the pharmacy folks that support them, and looking at a product, building it there on site, testing it, adjusting it, and working on it in that way, rather than trying to build it here in the DC area and then push it out to folks without getting full input from them. So that's where we're hoping to head. But we've got a ways to get there. This is technically some of the comments on where we are today, and there's a lot of things here that can be interpreted multiple different ways. Our agency modernization strategies, we're trying to synchronize those to a common architecture. That's one that has received some scrutiny here in the last couple days. We don't really have a common architecture yet. We have different acquisition policies, different life cycle processes. We have different organization structures, different funding streams. It's very challenging, but these are all the things we're trying to kind of reconcile and get in place so that we can move forward. And then this is where we're going. We would like a single organization structure for agile execution of this. We would like clearly delineated roles and responsibilities. That's on both the VA and the DoD side. And we want the other things that are listed there, which all sound very nice, and I'm sure everybody would agree it would be wonderful. It's just going to take a lot of unified strategy and synchronization, as it says there in the blue box, and it's just going to be a lot of work over the next several years. And as I mentioned, that means that for about 5 years we're probably going to have what we have, and we're going to need to figure out how to maximize our use of that. So right now with our current systems, we are still working on maximizing speed, availability, and usability. I think that you all know the pain that is there with AHLTA speed and availability. Usability we have tackled through things like maps, and there's more that we could do there, but those are some of the things that we're going to focus on. And then supporting our legacy systems to make sure we can still get access to what we need to take care of our patients on a daily basis. And so those are the things we're focusing on right now. Wanted to just touch on VELR because you all will start to hear about this more as we move forward. This is the federal interagency initiative to share data between Veterans Affairs and DoD for service members as they transition or as they're getting care in both systems. And VELR is not a system per se. It's a way of bringing data together to be viewed, and it stands for the Virtual Lifetime Electronic Record. It's supposed to be an entire record, not just medical. It's supposed to be virtual lifetime record to include financial information, personnel information, benefits, death benefits, all the way through the life cycle of the soldier, and medical. And so medical was one of the first places that they decided to start, and so right now VELR is largely just the medical component. And right now through TRICARE Online you can access the blue button, and this is one of the ways that they are helping to bring data together from both of the systems for patients to see it. And in the backup slides I believe you have a view, just a screenshot of what this looks like for a provider. It is not perfect. There are challenges because the data being pulled from DoD is being pulled from CHCS. So if I am sitting in Florida and I want to see somebody's information and they have some information sitting on the CHCS host in at Fort Lewis or Joint Base Lewis-McChord, and the system does a query and that CHCS host happens to be down for maintenance or anything else, then that information would not get gathered and you wouldn't see the full complete patient picture. So there are some things that we're trying to do to improve that. The reason I say you all may start hearing about this is that this is a very political topic, and it does appear that we are going to roll this out DoD and VA-wide starting this fall. The DoD is taking a very a very slow rollout approach because there are some of these technical issues that still exist, but you will start hearing more about this as we go forward. And I think that that's the gist of my slides, and I know I went through a lot of that really quickly. I would be happy to take questions, and I'm going to take myself off of the talk, so I'll open it up to questions.
And again, if you have a question, please.
I think Eddie was going to say if you have a question, raise your hand or just speak. I'm not sure, Eddie, you cut out.
That was correct, ma'am.
Any questions? Okay, I'm not hearing any questions. I did see a couple things. Somebody I know asked about whether or not the slides would be available. I see that somebody has put in the website address, and then I know there was a question about the SMS dashboard, and Dr. Jones, I think I saw that you had replied.
Colonel Quirkenbush, this is Arlene. Yes, we did.
Okay, is there anything else?
Eddie, I think we had a few survey questions at the end that we wanted the audience to answer. Thank you, Colonel Quirkenbush, for your time. I appreciate the valued information that you've provided to the folks on the call today.
Great, thank you.